So the normal mitral valve, of course, there's a anterior and a posterior leaflet. Um, the normal opening or the area of the mitral valve is about 4 to 5 centimeters squared. And when we talk about mitral stenosis, we talk about a narrowing of the mitral orifice. That's an opening. So the opening is narrowed. What are some of the causes? What are some of the things that can cause mitral stenosis? Again, rheumatic heart disease. Worldwide, rheumatic heart disease is the most common. But if you're in, one of the developed country, the U.S. and Europe, senile degeneration uh, might be more common. Um, but you're still going to get people traveling from underdeveloped country to the U.S. and Europe. So you're going to see an occasional patient with rheumatic heart disease, uh, in infective endocarditis. So when you have an infective material on the mitral valve, it can obstruct the opening of the mitral valve. And then tumor, myxoma in particular, can obstruct the mitral uh, inflow. Okay, so you know, imagine a mitral valve that's opening, and you have a myxoma that's trying to get out of the left atrium. So it's going to block the mitral valve orifice, because when the mitral valve opens, the tumor is going to try and get out of the atrium. So it's going to block the mitral orifice. So these are probably some of the most common cause. The most common one, however, is rheumatic heart disease. What are some of the signs and symptoms of mitral stenosis? So the pathophysiology is obstruction to the mitral valve. Blood cannot get out of the left atrium. So the left atrium is going to get large. Those patients develop atrial fibrillation. They develop pulmonary hypertension. And because they develop pulmonary venous hypertension, um, they can develop pulmonary edema, the lungs flooding with fluid, and they tend to cough up blood because the increased pulmonary venous pressure can cause damage to the capillaries. So they will present with shortness of breath, exertional at first, PND, that is, they go to bed, they're sleeping, and then they have to get up a few hours later to sit up and breathe, or they just can't lie flat at all. Orthopnea, they have to prop themselves up with multiple pillows. Palpitation, because again, the blood cannot get out of the left atrium, so the left atrium gets enlarged, and those patients commonly develop atrial fibrillation or atrial flutter. So they can present with palpitation, and they can develop PACs and PVCs as well. But if it's a significant mitral stenosis, some of those patients will develop atrial fibrillation. Chest pain, um, hemoptysis, that's a blood in the sputum because of the increased pulmonary venous pressure. Thromboembolism, because if the atrium gets huge, the left atrial appendage, uh, blood can stagnate in the left atrial appendage, and you can get blood clots. And worse, if they develop atrial fibrillation, then they definitely will form blood clots in the left atrial appendage. Those clots can break off and travel. So a patient can get strokes, they can get uh, blood clots going to the gut, they can get dead gut, bowels can die. Ascites, because of the pulmonary venous increase in pulmonary venous pressures, increase in pulmonary arterial pressure, and they can develop ascites. Leg edema, for the same thing, pulmonary hypertension, it increase pulmonary pressures, pulmonary hypertension, and they can develop leg edema. The classic murmur for mitral stenosis, what we call a diastolic rumble, because the mitral valve doesn't open to its full extent, so the blood, there's turbulent flow. When the mitral valve tries to open, the blood flowing across the mitral valve is going to experience turbulence, and that turbulence you hear is what we call a diastolic rumble. And when the mitral valve tries to open, um, we talk about the S2 opening snap, So the mitral valve, so your S2 would be when the aortic valve close, and then you're going to have diastole now, so the mitral valve is going to open, but it opens with a sound, and that's what we call the opening snap. And we commonly talk about the S2 opening snap gap. So that's the time between S2, which is the closure of the aortic valve, and that opening snap. The shorter the time, the more severe the mitral stenosis. So those are some of the things clinically that we use. Okay, all right. So when you look at your echo, your mitral stenosis is sort of classic if it's due to rheumatic heart disease. So if your mitral stenosis is secondary to rheumatic heart disease, you can almost uh, make the diagnosis by just seeing your parasternal long axis view. And those of you who are going to be doing exams, they will give you a classic case and ask you what's the most likely etiology. So if you look at the anterior leaflet of the mitral valve, it's thickened, okay? And there's an archistic appearance of the anterior mitral leaflet. So it has this archistic appearance, and of course it's going to be thickened. Most of the calcification is going to be at the tip. And again, the subvalvular apparatus commonly is involved. So the subvalvular apparatus, which includes, of course, the chordinae tendineae, and the papillary muscles to a lesser extent. The cords will get shortened, thickened, and calcified in some of these cases, okay? So that's the anterior mitral leaflet. And again, we talk about the archistic configuration of the anterior mitral leaflet. So we're going to go over this multiple times. So once we finish the lectures on mitral stenosis, you should be comfortable in identifying rheumatic. So another thing with mitral stenosis, because the blood cannot get out of the left atrium is enlarged. So you can see in this case, it's measured with the linear dimension is 5.66 centimeters. The upper limit is 4 centimeters, of course. So this is very enlarged, and that's in keeping with the pathophysiology of mitral stenosis. And then if you were to look at the valve, say, in the short axis view, okay, you can see the valve is going to be thickened and restricted opening. We commonly, in determining the severity of the mitral stenosis, there are certain things you have to do, and one of them is doing planimetry of the mitral valve. That is, you just trace the opening to get the area. But you have to be careful because the mitral valve, when it opens, it has a conical shape. And if you remember what a cone looks like, it has a narrow the base is broad and the top is narrow. So you have to find the narrowest portion of that cone, and that's what the area is gonna be. So you have to uh, look at multiple levels of the valve, and then when you find the narrowest portion, then that's where you're gonna do your planimetry and get the area. Okay, so again, this is our case, rheumatic mitral stenosis. So this is our left side of the heart is there, the right side. Okay, your left ventricle. This is the muscles, this left ventricular cavity here. Mitral valve is right there. Anterior leaflet and the posterior leaflet. You can see that your left atrium is huge. And you can see this is a diastolic frame. So the mitral valve should be fully open. And you can see that there is restriction to the opening. Okay. The acoustic configuration, that's what you're going to see in your parasternal long axis view. And then when we talk about the subvalvular apparatus, okay, so you concentrate on the caudate tendineae, okay, which anchors the leaflet of the mitral valve to the papillary muscles. Okay, so this the frame we showed you at first, diastolic frame, where the mitral valve's supposed to open, and this is a systolic frame where the mitral valve is supposed to be closed. You can see the large left atrium. All right, so how do you assess the mitral valve? You suspect mitral stenosis. There are a few things that you need to do. So you need to get good pictures, okay? So you're going to do your routine echo, your parasternal long short axis view. You will do your apical 4 5-chamber view. You do your apical 3-chamber view, 2-chamber view, and you do all the views, okay? But there are certain measurements that you have to do to determine the severity of the mitral stenosis. Okay, so you can use the gradient. Okay, however, the gradient is probably the least accurate means of assessing mitral stenosis because the gradient is affected by the flow. So and it's affected by the heart rate. So if someone is tachycardic, increased heart rate, that in itself can increase the gradient. And if you have increased flow for whatever reason, that can increase the gradient. So be careful about the gradient. Or grading severity is has changed. So these numbers are no longer what we use. As a matter of fact, what we're saying now is if the gradient is greater than 5 millimeters mercury, then it's severe mitral stenosis. Okay? So we're going to go over the current grading system, but just to let you know that this is the whole grading system. This is the whole grading system. We don't use it. The current one is if the mitral gradient is greater than 5 millimeters mercury, it's severe. Okay? And then if it's greater than 10, it's very severe. So we'll go over the current grading system so you're familiar with it. And when you're doing the gradient, you have to use CW, continuous wave Doppler, to assess it. Be careful when the patient is in atrial fibrillation, you have to use 5 cycles and then average them. So you're gonna do tracing of 5 mitral inflows, get the gradient, and then divide it by 5. You're going to add them up and then divide it by 5 to get the mean gradient. Again, remember that your gradient is going to be affected by the heart rate. The greater the heart rate, the greater the gradient. So if you're assessing someone the severity of mitral stenosis in a patient, don't do it if the heart rate is too high, because you're going to get a very large number and you can't treat the patient based on that large number. Again, the flow across the mitral valve, if you have increased flow, then the gradient is going to be increased. So anything that brings about increased flow across the gradient, anything that increased flow across the mitral valve is going to increase the gradient. So similarly, if the patient has significant mitral regurgitation, so you're going to get backflow of a lot of blood into the left atrium, so therefore the forward flow across the mitral valve is going to be increased. So that in itself, significant mitral regurgitation will increase the gradient, and increase heart rate, increase flow. Okay? So if you were assessing someone with mitral stenosis, then your apical four-chamber view is on top. Your cursor is across the mitral valve. The sample volume is at the mitral valve, and you just press C doubler. So this patient has atrial fibrillation, so you can see the envelopes are going to look different. So this is your mitral inflow. This is another mitral inflow, and then you get another mitral inflow. So in atrial fibrillation, they're going to look different. So that is why you need to get at least five cycles and do it. Okay. All right. So the gradient. So remember, the gradient is not the most accurate means of assessing mitral stenosis, because it varies with a lot of things: heart rate, mitral regurgitation, uh, the flow across the valve, you know. So, but we still use it. It's one of the tools to assess the severity of mitral stenosis. Again, we did touch on planimetry, planing the mitral valve area. So you need to get your short axis view at the level of the mitral valve. And again, remember that the mitral valve, when you open the mitral valve, it's a conical in shape. So you have to get the narrowest portion. So when we talk about planimetry, it's the direct tracing of the mitral orifice from the parasternal short axis view. You're going to scan from apex to base to ensure that the area is measured at the leaflet tips. Okay? And you're going to zoom. Whenever you're doing any measurements in echo, zoom, because by doing that, you reduce the errors that will result. And this just to show you that the narrowest portion is at the leaflet tips. And when the valve opens, the valve apparatus is conical in shape. Okay? So you want to do planimetry of the narrowest portion. Again, you have to look at the entire valve apparatus to get the narrowest portion of the leaflet tips. And all you just do planimetry around the opening, and you'll get the mitral valve area. So we look at the pressure half-time method, we look at planimetry. The other method we're going to look at is the pressure half-time. Okay? And as the name suggests, the pressure half-time is the time it takes for the pressure to fall to 1/2. Okay? as we did in hemodynamics, pressure gradient is equal to 4v squared. So you can figure out what the velocity is going to be at half the pressure. But basically, it's the time it takes for the pressure across the valve to fall to fall to a half of what it was before. So it's a time interval in milliseconds between the maximum mitral and the point where the gradient is half the maximum initial velocity. Essentially, what we're saying, it's a time it takes for the pressure to fall to one half, not the velocity. You have to take into consideration that the pressure gradient is equal to 4v squared. So you can find out what the velocity is at half pressure. So they when they work out the formula for mitral valve area, it comes out to 220 divided by the pressure half time. Again, the pressure half time is time it takes for the the pressure to fall to one half. You need to get your Doppler spectral. You need to have your C doubler of the mitral inflow, and you can get the pressure half time from that. Okay? Well, you have to know that the formula, that the mitral valve area is equal to 220 divided by the pressure half time to get the mitral valve area. So these are some examples of what to do and what not to do. So if these are two mitral inflow, to get the pressure half time, you need to get this portion. Don't get the initial portion. It is this portion that you need to just put your cursor, and the computer will give you the pressure half time. Okay, so you're not going to try and get the pressure half time for the first portion. Okay, this is the portion you need to get the pressure half time. And the formula is 220 divided by the pressure half time. The computer will give you the pressure half time. A very important relationship is the relationship between deceleration time and pressure half time. Pressure half time is equal to 0.29 times the deceleration time. So if they give you the deceleration time, you can calculate the pressure half time and still use it in the formula to get the mitral valve area. Okay. So this is an actual patient. So these are mitral inflows. Okay. So so these are C doublers of mitral inflow, and you do the pressure half time at this portion right here. You're not going to do it right there. So right there, and then the computer will give you the pressure half time, or if you get the deceleration time, the pressure half time is 0.229 times the deceleration time. And once you put it in the equation, then you get the mitral valve area. All right. You can also use your continuity equation to calculate the mitral valve area. Once you remember the fact that the flow anywhere inside the heart is going to be the same. Flow anywhere inside the heart is going to be the same. So if you want the flow across the left ventricular flow tract is going to be the same as the flow across the mitral valve. You know, so that's what the continuity equation says. So the flow across the mitral valve, a flow across anywhere is equal to the cross-sectional area times the TVI. Okay, so for the mitral valve, flow across the mitral valves is equal to the mitral valve area times the TVI across the mitral valve, and that is the same thing as the flow across the left ventricular flow tract, which is the left ventricular flow tract area, the area of the left ventricular flow tract times the TVI across the left ventricular flow tract. Okay, So if you rearrange your equation, then the mitral valve area is going to equal to the left ventricular flow tract area, the area going to the left ventricular tract, times the TVI across the left ventricular flow tract, TVI, and you're going to divide by the TVI of the mitral valve, okay? The continuity equation, okay? Flow anywhere inside the heart is the same, but we can use the flow across the left ventricular flow tract and the flow across the mitral valve. The unknown is going to be the mitral valve area because we can do planimetry and get the TVI across the mitral valve, okay? We can measure the diameter and we can get the area across left ventricular flow tract. We can use our PW and get the TVI across the left ventricular flow tract. So we can just put all the known and calculate the mitral valve area. So if we simplify the equation, okay, again, the left ventricular flow tract area is the area of a circle. The area of a circle is pi r squared, okay? When you simplify pi r squared, you get 0.785 times d squared, and then you multiply by the TVI across the left ventricular flow tract, and you're going to divide by the TVI across the mitral valve. So the okay, so it's a relatively simple exercise. You can also use the PISA method to calculate the mitral valve area. And if you're going to use the PISA method, which is a little bit more difficult, we use the same concept though. The flow across the mitral valve is the flow across the flow at pizza. All right, so the flow across the mitral valve. So if you have mitral stenosis, okay, the flow across the mitral valve is going to equal to the flow at pizza. The continuity equation tells us that, okay. The flow at pizza, if you remember from hemodynamics, it's the area times the Ellison velocity, okay? And then the flow across the mitral valve is the mitral valve area times the peak mitral velocity, okay? And then you just solve for the unknown, which is the mitral valve area. Because all of these, you can, from the pizza, you can get the radius. Ellison velocity is what you adjust, something you do in the lab, and you can just measure the peak mitral velocity. Okay, so these are all known. The only unknown is the mitral valve area. This is not a method that is used common, but you should be familiar with it. You have to multiply it by a correction factor though, because if you look at when we talk about mitral stenosis, you can see that the valve is not flat. The valve is not flat. There's what we call an opening angle. Okay, so the valve is not flat. So that is why we have this correction factor, which is alpha over 180. If it was flat, then alpha would be 180. So 180 over 180 would be 1. So the correction factor would be 1. But if it's not flat, as in this case, then you have to find out what this angle is, which we call the opening angle. And then you put the opening angle and you get your value. All right. It's very important for you to look at the anatomy, especially if the patient has rheumatic heart disease, because when you're giving your report, you have to tell the patient. So you have to tell the the person who referred the patient to you what the valve looks like. So, it will help that individual to determine, should I get a repair on this valve or should I just replace the valve? Okay. So it determines the choice of treatment, whether it's valve repair or valve replacement. So, if it's a rheumatic mitral stenosis, then you can describe the artistic configuration of the anterior mitral leaflet. Okay, that will tell them that it's a rheumatic etiology. You have to also tell them about, is the valve mobile? Is the valve thickened? Is the valve calcified? And then with the subvalvular apparatus, the same thing. Is it shortened? Is it thickened? Is it calcified? All those things are going to help you to determine whether you can repair the valve or you have to replace the valve. So when we're looking at mainly rheumatic mitral stenosis, these are the things that we look at. And this is called the Wilkins score, okay? The Wilkins score. And we look at the mobility of the valve thickening, calcification of the valve, and then subvalvular thickening, okay? So there is a grade from 1 through 4. So when you look at the valve, if the valve is highly mobile, it's not very thick, not much calcification, and minimal subvalvular thickening, then for each of these points they get a score of 1. So a score of 4 is very good, because that patient can have valve repair. You can repair the valve, so if the valve is either mobile, the valve is not thickened, the minimal calcification and minimal subvalvular thickening. That's a good valve for repair, as opposed to a valve where there's no or minimal forward motion of the valve, so the valve is not very mobile. You talk about thickening, considerable thickening of the valve is very thickened. And then when you talk about calcification, extensive calcification throughout the valve. And then when you look at the subvalvular thickening, extensive subvalvular thickening and shortening of all chordal structures. And then so each of these points will get 4. So mobility 4, thickening 4, calcification 4, subvalvular thickening 4. So this total score here will be 16, 4 times 4. This patient would not be a candidate for valve repair. This patient would need valve replacement. You'll have to replace this valve. So again, when you look at the valve, the things that you're going to look at, 3 things for the valve: mobility of the valve, calcification of the valve, and thickening of the valve. For subvalvular, you're just going to look at thickening and calcification, okay? So the minimum score 4, maximum score 16. The lower the score, the more reasonable it is to repair the valve, okay? So we're not gonna, this is not the current um, severity grading system. So we're not gonna look at this because the grading system has been updated. So when we meet on Thursday, we're gonna go over the current grading system. All right. So, but you need to know how to assess the mitral valve. You need to know what your rheumatic mitral stenosis looks like, and the different methods to assess stenosis, and how to implement these methods very important. All right, so we're gonna stop here, and on Thursday we're gonna look at the current grading system for severity and go into some other uh, aspect of mitral stenosis.